Good afternoon. For me, it is a great honor and a great pleasure to participate in the conference of the Mexican College of Urology. It is a pity that we cannot meet face to face because of the pandemic, but anyhow, I'm sending a virtual affectionate embrace to my Mexican friends. I will be speaking on the management of female and functional urology during the COVID-19 pandemic. And really, in the beginning of March last year, during the full lockdown because of the pandemic, it would seem that the only important thing were the patients that had the COVID infection, forgetting that there are other pathologies that require immediate attention in order not to have a lethal outcome. Because of this, the European Association of Urology, through the different committees of the panel of the clinical guidelines, established a report for determining priorities for the diagnosis and the therapeutical point of view, classifying these priorities as low priority, intermediate priority, high priority, or urgent. From the diagnosis point of view, the European Association of Urology recommended deferring functional problems and only evaluate urinary incontinence when the cause of incontinence could be attributed to an oncological cause. And so appointments were cancelled, patients no longer came to the hospital. We started doing telemedicine, telephone contact with the patients. In regards to the treatment, the European Association of Urology recommended even deferring conservative treatment, labeling it as low priority, and urgent treatment would be that which clearly threatens the life of the patient. They not only recommended deferring conservative treatment, but also pharmacological treatment, except for the patients that are on desmopressin because of the obvious risk associating to having hydroelectrolytic disorder, which can occur in the patients that are on desmopressin for the treatment of nocturia. In regards to surgical treatment, the European Association of Urology also recommended delaying the treatment of those benign pathologies such as stress urinary incontinence, mixed urinary incontinence, urethral diverticulum, prostectomy incontinence, and even the treatment of the fistula, the non-obstetric urinary tract fistula, which are the ones that we normally see in our centers. In regards to surgical treatment, fistulas were established as a priority, and considering treatment based on particular cases. In other words, analyzed on a case-by-case situation in order to establish the priority of the surgery. Because of this, there was really a barrier, a wall between the attendings, let's say, between health practitioners and the patients, in such a way that these pathologies were somehow abandoned. As a consequence of the pandemic, these patients were deprived of appropriate medical care. This happened throughout the world. In this paper published by a group, the Eurosomi group, which is a group of urologists from different parts of the world with a particular interest in social media, they did surveys to demonstrate that there was a dramatic reduction of all of those procedures focused on benign pathologies, both from the diagnosis point of view as well as from the surgical treatment. There was a reduction of all pathologies. In oncological pathologies like testicular cancer, there was only a reduction of 15%. But in regards to benign pathologies, such as benign prostatic hyperplasia, incontinence, and so forth, there was a reduction that was close to 90%. The urodynamic group validated urodynamic practices during the pandemic. They, in fact, validated the previous study, how there was a dramatic reduction, close to 90% of all benign pathologies, hyperplasia, female urology, urodynamics, uroflowmetry, and so forth. It was clear that there was a halt in attention on benign pathologies. They concluded guidance to give orientation on good urodynamic practices that one must consider the base pathology in order to establish the priorities. For example, in the case of dislodged bladder, or if there is a risk of deterioration, or when to do the urodynamic studies, do the clinical history over the phone, ruling out that the patient doesn't have COVID personal protection equipment according to the regulations in each center. And in order to avoid the spread, instead of doing the cough test to determine the presence or not of a stress incontinence, or during the urodynamic test, do the Valsalva maneuver. Another Italian study demonstrated the same findings of a dramatic reduction in benign pathology treatment, and they concluded that this delay, which included a clear increase in the surgical waiting list, could take a minimum of 2 years and a maximum of 5 years in recovering, in other words, of returning to normality, which gives you a clear idea of the serious effect that the pandemic has had on benign pathologies. Other places, other countries, for example, these recommendations from the Cleveland Clinic also established priorities when tending to the patients, considering something as emergency or non-essential. From the functional point of view, for example, priority is given to the second stage of sacral neuromodulation, among other things, because there can be an infection on the electrode. That is why the recommendation was to either do it soon or to cut the wire in order to avoid the infection and reimplant the battery or the neuromodulator in a second stage. Non-essential surgeries are the sling, the pelvic organ prolapse, sacral neurostimulation stage 1, or artificial urethral sphincter circumcision, and so forth. And the same thing happened also in Europe. They followed these same recommendations, and in fact there were different reactions in Europe, in different countries. In Italy, for example, the Finazzi group; in France with Michel and headed by Yves Carcenti; and also in Europe, the European Association of Urology. They recommended certain, let's say, instructions, in order to avoid or in order to minimize the effect of the pandemic on functional pathology. Clearly, the pandemic is going to last longer than what we had thought, and it's obvious that we have to treat non-oncological patients because, in fact, they will have sequela, and this can be important. It is clear that we must consider if functional pathologies do not kill, although they can, if they are not detected and treated appropriately. Clearly, there is an enormous impact on the quality of life. In Spain, the Association of the Surgeons was a pioneer in determining other parameters when establishing priorities based on staging, based on bed occupancy in the intensive care unit, because that was the fundamental problem, that the authorities observed the collapse of the hospitals and the collapse of the intensive care units. At a given moment in a city in Spain, it turns out that there weren't enough ventilators to tend to the patients that needed it, placing the physicians in a very difficult situation of deciding who to place on a ventilator and who not to. That was an extremely grave situation to which we had never been exposed to. Based on the staging, based on the intensive care unit capacity, there were different levels established: 1 normal, 2 alert, 3 medium alert, 4 high, and 5 emergency. In regards to this staging, well, the Spanish Association of Surgeons established these recommendations, allowing in this way to classify which patients could be treated initially and which patients could be postponed. In urology, also the Spanish Association of Urology and other groups of the association also determined, let's say, suggestions for what is considered the de-escalation once the pandemic has been controlled, once we're come out of confinement, classifying it in almost normal, mild alert, or medium alert. But I always insist on telemedicine, because if the pandemic has taught us anything, in my experience, is that it is possible to solve many of the problems that our patients have through telemedicine. Patients appreciate being called. They like us to call before them coming to the office. If necessary, they come to the hospital, and if not, they are happy in being treated over the phone. And the same thing happens in regards to surgery and surgical techniques. In this case, as I have said before, the case of sacral neuromodulation, if there is a mild alert, the recommendation is that the patient has already had the first stage of neuromodulation. It is recommended to cut the wire while they await for the second stage. Only surgery for cytis plus D augmentation or botulinum toxin in order to reduce the neurogen hyperactivity for the patients that have bladder at risk. The Association of Surgery, a group of urologists with an international character, classified the procedures of functional urology and female urology depending on the urgency, considering as urgent, elective urgency, an intermediate priority, a discretionary priority, determining the different procedures that could be or could require urgent care. For example, abscess, because it is life-threatening, septicemia, urinary retention, if it's not possible to place the catheter, hemorrhage, and hematuria in the patients that bleed and who we cannot control, particularly in female urology procedures. Postponing till after the pandemic has been controlled, or the index of persons infected per every 100,000 inhabitants has gone down. Other procedures like elective surgery for incontinence or pathologies that are benign, let's say, that do not have any impact in the amount of life, but clearly in the quality of life. This same group then concluded that not all of the clinical situations can be attended to on a video call or a telephone call. Physical evaluation is essential when required. the pandemic scenario is fluctuating in time, and not all of the hospitals in the same country will have the same situation, depending on the occupancy or hospitalization and intensive care unit capacity. In functional urology, there are also patients that have risk pathologies that should be urgently treated. Preferably speaking, it's possible to do the surgery on an outpatient basis with local regional anesthesia, which reduces the risk of hospital infections and the risk to practitioners. In my hospital initially, in the confinement, activities were paralyzed, only the ER continued to operate, but bit by bit we started receiving more patients. Obviously, there was a delay, but with the implementation of the vaccine, it is expected that the number of cases per 100,000 inhabitants will be reduced, and it will be possible to tend to a greater number of patients. I would also like to consider the point of view of the anesthesiologist. They recommend that for elective surgery, the recommendation is 10 days after the symptoms of COVID have disappeared in mild disease, or 15 or 20 days in severe disease. An increase of morbidity and mortality if the surgery is performed before this time in patients in which the disease persists. Always perform a balance between the perioperative risk and the progression of the disease-based disease or the clinical priority. Vaccination before the surgery would obviously reduce the risk, and given the higher risk of morbidity and mortality, measures must be taken in order to avoid receiving patients that are incubating the virus. That is why in our hospitals, before the surgical procedures, we would require a test. We would order a PCR to demonstrate that the patient was free of coronavirus. To close, we're still yet to see, from the urological point of view, are the consequences of the COVID infection, because as time progresses, we're starting to see reports that warn us on the possibility of viral cystitis, on the possibility of hematuria, and of an atypical evolution of the inferior urinary tract infections of cystitis associated to an elevation of cytokines, as demonstrated by Chancellor's grouping, or testicular inflammation and alterations of the spermatogenesis. The consequences are not yet known. Summing up, the functional urological pathology, without a doubt, is the most affected during the pandemic. There is a delay in diagnosis and treatment of functional pathology. There is an increase and delay in the waiting list that will take years to recover. We need to readapt the priorities in female urology, adapting them to our reality, maximizing the safety of the patients and practitioners. It is precise to consider that benign pathologies do not kill. They do not kill. They do worsen the quality of life, and they affect productivity. It is precise to consider this because clearly oncological pathology requires special attention, but there are benign pathologies that could also wind up in a lethal outcome. Thank you very much for your attention. I wish my Mexican friends of the Mexican College of Urology to have an excellent conference, and obviously speaking, that they stay safe and that they recover soon from the pandemic.